What is up, my peeps? Joshua Smith here with another GSD interview. Every single week we interview top entrepreneurs and just straight up top badasses, guys. They're out there dominating their space. These are people that are choosing to not live a life of mediocrity, but instead to go out there and create big lives, massive opportunities for themselves and their families. So today you guys got a special guest on, a guy been trying to get on the show for a long time. He's extremely busy, but we finally got him on the show. Really excited and honored to have Dr. Brett Osborn on the show. Welcome to the show, my friend.
Thank you very much. Appreciate you having me.
Yeah, I love it, man. You know, you got so much going on today. I mean, you're one of the top neurosurgeons really in the planet. You've got an anti-aging health clinic, optimal health clinic. You're a best-selling author. Those of you that watch and listen to this podcast, I'm always plug in Dr. Brett Osborn's book. In my opinion, it's by far the best read for overall health, fitness, nutrition that exists out there. Get serious. But before we jump into what you're doing today, I'm always interested on our guest journey of what led you to this path. I mean, what led you into becoming a neurosurgeon, and then eventually, you know, we'll get into your new clinics that you're doing and becoming an author. But what led you on this path?
Right. So that's a great question. And actually, I'm asked that fairly frequently. And I think that distilled down, I think that probably the best answer is that I was really I was a tinkerer growing up. I was always one who was fiddling around with things, using my hands as much as possible. I was into technology. I had a very, very strong foundation, or I do have a very, very strong foundation in electronics. So not the electronic where you're using those sets that have the connect the wire to this spring and that spring. I was into the discrete electronics, so actually building circuitry. I was the kid that at 16 years old. So this was in 1986. Before you can buy a laser diode that worked on 1.5 volt batteries. I was the guy who had the big tubes with the 1,000 volt, kickstart power supplies, and we thought the best thing ever was a 1 milliwatt laser. Now you can go and buy a 100-watt laser, which runs on less than 5 volts, that you can carry around, and that's this big. It's a portable little device. So I was into a lot of things. That's just one thing. I was also into some I'll just sort of label them loosely as pyrotechnics and things like that. So I was always fiddling with things. So neurosurgery was sort of it was an easy sort of transition for me by virtue of that. Because I always wanted to use my hands. I was always into human performance, and obviously, as you know, I'm into it. I'm still into it now, and more so than ever. So neurosurgery is the natural. It was the natural path for me. So that's a mental performance. It's also physical performance, and the anti-aging stuff is in my mind. And we'll talk about this, I guess, a little bit later. It's for reasons that at least I have in my head, these things are one and the same, or they sort of run in parallel with another. Because that's sort of physical human performance. Neurosurgery is the exact same thing. So in terms of technical abilities in the operating room, and I was thinking a little bit about this yesterday because I did a very, very complex high cervical case. A woman had a C2 fracture, so way up in the cervical spine, and we're putting screws into her vertebrae at C1 and C2. Which is a complex operation. We're putting these small screws, a millimeter away from not only the carotid artery, but the vertebral arteries. So you have four arteries that run through the neck to the brain, and we're putting screws millimeters away from each one of these things. So this is just, if you know me, and you knew me growing up, this was just me. It was either neurosurgery for me or it was just nothing. And that's just the way I am about things. It's very, very binary with me. So that's a long-winded answer, but we can touch upon little aspects of that if you have questions.
Yeah. So, you talk about also the interest at the same time when you were young into the health and fitness space. And I know that's a big passion of yours. You obviously take amazing care of your own body, but I know that you have a passion for bodybuilding and a lot of these things. Was that an early passion as well, or did you develop that later in life?
Right. So again, same theme here, Josh. It's not the bodybuilding was aside. I'm not a fan of the sport, and I think I've said this probably to a lot of people who've come in here as patients, or a lot of people who have who know me and know what this stuff is about. The look, the bodybuilding is a side effect of the life. Bodybuilding unto itself, I really don't have any interest in. It's a drug-laden sport, like a lot of sports are, and it's the look is is the means to an end. That's not the way it is with me. With me, you want to make your body as healthy as possible, as strong as you possibly can make it, moving into your later years, because muscle is protective of the body. We all know that. And by virtue of that, by virtue of doing the right things, strengthening your body, using the proper techniques, and more specifically avoiding injury, you're going to attain that look. It's just, so I call it a side effect. It's not we are lifting weights to have bigger muscles. But in answering your question, has that always been something that I've been interested in? Yeah, it has, because human performance, just like performance in the operating room, so surgical performance or technical prowess, that's always been very, very interesting to me. And these two things, again, there's just another parallel here. These things are one and the same. So while we might be using our hands in the operating room, I like to think that while I can use my hands in the operating room and do very, very complex technical things there, I also like to think that I can go and deadlift 500 pounds. And the two things typically are completely incompatible. So when people see my hands, they look at my hands in the office, because people always look at your hands. My dad always used to say that. They're always going to look at doctors' hands, always. And surgeons' hands are typically like, or they're stereotypically like a pianist's hands. So they're long, thin fingers, right? Well-groomed nails, no calluses. Well, look at these things. I mean, these are like, I have big hands. They're thick. They have, the iron grip, for holding up, for lifting 500 pounds off the ground. That's not surgeons' hands. Those are not surgeons' hands at all. But I actually take pride in that, because I don't want to be, the surgeon that has the long, lanky fingers with no muscle and can only deadlift his body weight. That's pathetic.
Yeah. Yep, love it. So, all right, so you've got this path, this career that you've taken as a neurosurgeon, and I know you're extremely busy doing that. I mean, at what point did you decide to go open up a separate clinic? This optimal health anti-aging clinic that you've decided. I mean, at what point in your life and your career did you decide that, and why? You're so busy as a neurosurgeon. I'm sure you don't have a lot of time on your hands. I mean, what drove you to do what you're doing now with that?
Well, I mean, I'm equally, if not more so, passionate about that stuff than I am about neurosurgery, because neurosurgery, like mainstream medicine, I'll call it that. Not that this is alternative medicine, but it's a little bit more on the fringe, I would say, it's a reactive type of medicine. And I would say midway through residency, and I think I talk a little bit about this in the book, midway through residency, I was saying to myself, if people just tried to prevent these diseases by taking care of themselves, by eating properly, by exercising every day, by putting the right supplements into their bodies, by trying to utilize some sort of stress reduction techniques, the themes that are touched upon in Get Serious, we wouldn't be doing these operations on patients. So, or a lot of these operations on patients. Like I just got out of the operating room an hour ago. And if this gentleman had been doing the things that he should have been doing, I'll say that, should have been doing, he wouldn't have needed the operation. So that sort of fed into my, my what do you call it? I don't know, I guess my longing for an outlet, in this regard, and particularly in the wake of the book. And I had been dabbling in this type of stuff elsewhere when I was in practice in West Virginia for a little while. But I figured that since I was down here, where demographically speaking, for a variety of reasons, the majority of individuals are, at least to some degree, health conscious. I figured it was an excellent forum for me to, sort of open up shop, again, particularly in the wake of the book. So this is the clinic, as I always tell my new patients, is really the embodiment of Get Serious. And how have I been able to do it time-wise? Well, just like you, you're an extremely busy guy. I mean, I follow you on Facebook and social media, et cetera, et cetera. So I know you run around too. You figure it out. You carve the time out because it's important to you. So that's what we've done here, and it's interesting. I've because I'm not a businessman, or I'm a decent businessman as a doctor, but doctors are terrible businessmen. So I'm probably a crappy businessman, and they're just horrible, the majority of them. But I'm learning. And we've taken on the former editor-in-chief of Muscle and Fitness from the mid-'80s to the early 2000s. His name is Tom Dieters, Dr. Tom Dieters. He's the CEO here. So he sort of helps me manage my time. So he, based upon clinic volume, will allocate time for clinic and allocate time for a trauma call and my neurosurgical responsibilities, obviously, aside from those things that are urgent or emergent, I need to tend to immediately. So it's been very, very interesting in that regard, and it's been a challenge, but we're pushing through. We still don't have everything right, but we're learning.
Yep, I love it. I love it. So, when I first met you, my wife and I, we came out to Florida to meet with you, and had a lot of different tests done. And at the time, I'm 34 years old. My physician here has always been like, every time I get my yearly physical, oh, you're healthy as can be. You do your workup, and you're like, well, man, you're not quite as healthy as you can be. There's a lot to go to work at here. And that's why I love your book, because it's like, we've got to wake up. We can't just trust our regular physicians, and you got to take your health into your own hands. So with that being said, what are some of the big mistakes or things that people need to watch out for that maybe listen to this podcast that are going to their regular physicians, getting things tested? Like, what are some of those biomarkers, if you will, that they should be looking for? Because when I tell people that I went to you and having different heart tests done and having, my arteries checked for atherosclerosis, like in your 30s, you don't need to start doing that stuff yet. But to me, it's if this stuff can be preventative, I'm going to do everything I possibly can to prevent it.
Right, and that's the that's really the underpinning of the entire book and the premise of this practice. We've opened up several different portals. I will call them portals of entry into the practice. So it's not just, well, you come as as an age management patient. Now we're doing things for weight loss, and we're doing things for diabetes reversal. We're doing things for cancer prevention. We're doing things for we have another one, which is an Alzheimer's prevention portal. But when it distilled down, or when it's all boiled down, what we're really talking about here is the same disease. And I think I told you and Amanda this. So you can call them whatever you want. You can call it cancer. You can call it diabetes. You can call it atherosclerosis of the peripheral vascular system. You can call it cerebral vascular disease, so heart attack, stroke. You can call it Alzheimer's disease. These diseases have very, very common underpinnings. And we talk a lot about this. And we're talking about insulin resistance, so that pre-diabetic state. We're talking about bodily inflammation. We're talking about oxidative stress. And interestingly, and as you know, you can measure all three of those things. Now, I don't spend a lot of patient money ordering tests for oxidative stress, but I do recommend that individuals at least take a look at their inflammatory markers and their level of insulin resistance. The oxidative stress is something that can be modulated fairly quickly in the body. It's very, very heavily dependent upon what you did within, say, the past 12, 24 hours, and also how much antioxidant you're taking. So these tests are expensive, and I don't think that they're really worth it, but you can measure oxidative stress if need be. So what we're talking about there is oxidative stress is the amount, as an example, if you're going to quantify this, of free radicals, or basically electrons that are bombarding the system in general at one time, and that evokes inflammation. And so we can measure downstream the inflammatory response with a number of things. And we use in my clinic, we use a homocysteine level, and you probably remember this. We also use CRP. There are other things called erythrocyte sedimentation rate, or an ESR, that you can get. It's a little bit less specific. So I use here, and this is by no means the end all be all. I use homocysteine and CRP. That tends to be these are the most prevalent tests. So those are two. For insulin resistance, we take, you can go as far as doing a glucose tolerance test, or an oral glucose tolerance test, which is a 3-hour test. You can do hemoglobin A1C, which is just a simple blood test, takes no time. You can do a fasting glucose, but there are other ways as well, more in-detailed, in-depth tests that you can use to measure your degree of insulin resistance. Other things that we use here, so other biomarkers that we use as far as laboratory studies are concerned. we use vitamin D3 levels. And I'm not concerned about individuals like yourself. I'm not even concerned about the middle-aged woman, about her bone density necessarily, particularly if she's well exercised. But I am concerned about the cancer chemopreventative effects of vitamin D3. So it's a cancer chemopreventative hormone. Yes, it is a hormone in the body. We take a look at your liver function test. We take a look at how well your kidneys are functioning. We also look at your hormone levels, as you know, testosterone, progesterone, estrogen. We look at progesterone. I use for exclusively for females, but men can be on testosterone too. On progesterone too. It's a much smaller dose, and thyroid. All of these hormones, they're like a symphony. They need to be in sync. They need to be very, very well balanced, or patients do badly. Bodily inflammation will go up if your hormones are suboptimal. We know this. If we carry around too much body fat, and that's another biomarker that we use. If we put you on the in-body scale, you know how much body fat you have. You know how much visceral fat you have. So not this fat that's underneath the skin, the subcutaneous fat, but the fat that's around the organs, the heart, the liver, the mesenteric fat, the fat around your bowels. We know that the more fat that you have on your body, the higher your inflammatories, higher your body inflammation is going to be. Also, in the context of visceral fat secretes things called cytokines, which are inflammatory mediators. And the higher your levels are of visceral fat, and it's an arbitrary scale, the closer you're coming to diseases which are associated with bodily inflammation, which is really every age-related disease: cancer, heart attack, stroke, diabetes, Alzheimer's disease, and in particular, we're concerned about the development of type 2 diabetes and ultimately Alzheimer's disease. So we put people on the in-body scale. Those are other biomarkers. Yeah, they're not laboratory tests. Those are biomarkers. Just like when you and Amanda came to the clinic, we had you guys screen. We want to see how well your brain's working. We want to see what your peripheral vasculature looks like early. We want to see what your heart's doing. These are critical biomarkers, and really give us sort of a handle on where you are in the spectrum of aging and age-related disease. So you want to get a handle on these things as early as possible. Why? Just like everything else that you do, so that you can track your progress or your digression, if you see your regressions. And we want to see patients getting better. So if you come here and your composite cognitive score, if you will, is X, well, we want to see that getting better over time. We don't want to see you sort of falling off. How do you do that? Same thing. So these are all the same thing. They're all the same diseases. Exercise, proper nutrition, make sure that your bodily inflammation is low or non-existent, making sure that your degree of insulin resistance is low or non-existent. And there are, like I said, many ways of checking that. You can check serum insulin levels. I didn't mention that. There's so many ways you can do that. Keeping your stress levels down. And all we're doing is initially, when individuals are, say, deconditioned, and this is not you nor Amanda, okay, but individuals that you bring in and they're insulin resistant and they're obese and they're not accustomed to exercise, what do we do with those individuals? Well, we actively push them in the right direction. So we get them on metformin, we start exercising, then we give them a modified ketogenic diet. I'll just use that term loosely. We set their carbohydrates, typically 75 to 100 grams, and we start driving them in the right direction. Then over time, once they start seeing changes and they get this positive feedback, then they become habituated to it, and they become habituated to success, and then it's sort of a self-propagating system, and then we need to see them less often. So we serve, on a variety of counts, not only as an individual or a clinic that's going to be able to assess your level of disease and sort of move you in the right direction, but we also, to some degree, serve as accountability coaches to those individuals that really, really need it. So I know that was a long-winded answer, but that's what we do here. It's very, very involved here. We're very, very much in touch with our patients, unless they tell us that they would prefer a hands-off approach. Most individuals do not. They like that feedback. We're aggressive about getting follow-up labs, et cetera, et cetera. So that's what we do here.
Yeah, no, and from going through the experience, I mean, it's an amazing experience. It wasn't like your typical doctor experience where you're rushed out. It was hours that between all the testings and then, you explaining in depth, hey, here's what this is, here's exactly what it means, here's the protocol to overcome this, and just an amazing experience. And what's cool about it too is, when I was with you, I had some definite things that I needed to change. My body fat was high, which would never be called out by my regular physician, if you will, but within like 4 months, I think I dropped about 9% body fat, and just felt amazing from it. And it wasn't like I was having to starve myself and do all these things and go through all this pain that most people think. It was just a few little tweaks that you did, and it didn't like massively disrupt my lifestyle, but turned around that health pretty quickly.
Yeah, absolutely. And this is the type of stuff that we are seeing in here. Not because it's me. I'm not trying to brag. I'm just telling you that we are very, very science and evidence based. We don't believe, in the context of getting people's body fat levels down. I don't cut any calories at all, zero. It's not about the calories. I think the calorically based diets are awful. And I'm sure you remember me telling you this. You want to keep that motorcycle engine revved up as high as possible. The way you're going to do that is you're going to feed it. You're not going to go on the Jenny Craig, the one cookie a day or the one shake a day, because ultimately, as what we call, in medicine, homeostatic. We are homeostatic organisms, so that means that we will try to come to an equilibrium and match, as an example in this case, metabolic demands with or not metabolic demands. Our metabolism will try to match what we are putting into our body. So you cannot go on a diet that is calorie restricted unless it would only be out of desperation. But there's no desperation, because we are not going to the prom in 2 days. We're not going to go on the feeding tube diet and starve ourselves. We are doing this as a lifestyle. So by virtue of that, you want to be eating right at your BMR and feeding that machine. Yes, the weight's going to come off maybe a little bit slower, but I'm going to tell you it's going to be sustainable weight loss. So I'm sure you remember me taking a look at the in-body numbers, taking a look at your basal metabolic rate, and setting you right there, and then working backwards after your macros. You cannot use calories to lose weight effectively long term. You will suffer. Your metabolic rate is going to slow down, and you're going to be yo-yoing your entire life. So that's a critical point, and we did that with you. And I don't know how aggressive you are now about following those macros, or it's been revamped since then, or et cetera, but we do that with everybody. And it's all because we just look at the data. We look at what the in-body scale gives us, and then we just start working backwards. So it's not a one-size-fits-all here. It's very, very customized and personalized, particularly in the context of diet, but also in the context of supplementation, hormonal replacement, et cetera, et cetera.
Yeah, and when it comes to when you talk about the customization, like my wife and I are both patients of yours. My wife's 110 pounds, and she has a different metabolism, right? If I ate her diet, I'd be 250 pounds. Right? So it's not a one size fits all. So you guys are reading those diet books. You got to understand, like, it is, everybody's body reacts different. So I love it. So at what age, for us, if we want to take our health into our own hands, at what age is too early? Is there too early? What age should people start this process?
No, there's no too early. So you do have some of the protective effects of our youth in terms of metabolism, hormonal profile, how much anti-inflammatory, I'll call them chemicals, one synthesizes in the body, your recovery capacity, and those things are all interrelated, obviously, which we don't have, or I should say we have them, albeit in a waning fashion as we get older. So as far as when an individual should start sort of understanding these basic concepts and getting active, getting healthy, or adopting a healthy lifestyle as early as possible. So my kids, I have them exercise, and they're engaged in sports and school and things like that. But that's a big thing for parents. You should push your kids into some sort of sporting activity as early as possible. If they are not individuals that they're more sort of cognitively oriented, I'll just say that, because my older boy is like that, and he's less of an athlete than my younger son, who's more of a maniac. That was like me when I was growing up. You still have to drive them. You find what they like. So he's a rower. He's been rowing now for about 6 years. Not a common sport, but still stays active in that regard. And he tends to, I always say he gets his metabolism from my father, who's sort of struggled with his weight all his life and has sort of done this yo-yo business with I'll call them diets, even though I don't like to use that word, all his life. And the way I have worked with him is that in addition to encouraging him to lift weights with me, to strength train, which he does, he actually has a very, very, very sound knowledge of the ketogenic diet. I explained it to him early on when I saw that he was getting a little bit heavy, that he needed to understand about the roles of insulin and how fat burning is triggered, how fat burning is turned off, if you will. And he actually is quite good at it. So over the summer, he got a little bit lazy. This is going on now. He got a little bit lazy because crew ended, and he rows about 9 months of the year. But for 3 months, he doesn't row. And then he starts putting on weight because he starts eating. He's not exercising, despite my my attempts at coercing him to do so. So I said to him, Jack, this is about, I don't know, 4 weeks ago. I said, Jack, let's start cleaning it up. Let's start getting back in the ergometer, getting back into the gym, and most importantly, because as you know, nutrition is about 90 to 95% of this. I need you to fix your diet, and he knows what that means. That means go on a full ketogenic diet, and I mean he does. He's an extremist. Go figure. So he won't go 75 grams of carbohydrates. He'll just go 0. So he goes nothing. So he's eating protein and fats all day, and weight goes like this. So, it's been, like I said, it's been about, 4 weeks, maybe 5, down about 25 pounds. So he's back into his sort of fighting shape already, and he's not even rowing yet. So, if you think about it, and I've said this many, many times before, these ketogenic diets are, they really are excellent for people that are engaged in endurance sports. They really, really are, because all you're doing is you're sort of stoking the metabolism that rowers use to begin with by virtue of feeding fat into those metabolic pathways. Because when you're rowing, there's a tremendous amount of oxidative phosphorylation going on. You're not really running on glucose unless, aside from maybe that last 250 meters, in which case you're fully anaerobic. But anyway. So that's, the answer to your question is get your kids involved early. There is no too early. At the very, very least, teach them about nutrition and how to eat properly. They're kids, they're going to eat badly sometimes, but you try to teach them in moderation, to limit it as much as possible, and really, really stress exercise. Do I think that they need to be on supplements? My kids, since a very early age, have been on omega-3s and probiotics. Those are two, I think, very, very important ones for kids from the standpoint of their immunity, from the standpoint of tempering inflammation, from the standpoint of their brain development, their heart health. I think those things are very, very important. I've actually we've fiddled around a little bit with Metformin in Jack as well, again to drive that fat burning process a little bit more aggressively. And I have several adolescents who've come to me under the guise of weight loss, who I put on Metformin. So teenagers, if they do have problems, in addition to cleaning up their diet and exercising, that's something that should be considered. Now, you had mentioned it before. If you go to your doctor, and he'll say you're healthy and all these other things, and he'll say, "What's Osborn talking about when you use Metformin on these?" Yeah, they're physiologically very, very similar, very, very similar beings to. Physiologically to us. So the answer to your question is that there's never too early. Never. I mean, my 4-year-old, we already have her, doing some little things out with my girlfriend, who's a nationally ranked hurdler in college. We have mini hurdles for her, so she's teaching her very, very early on. Listen, all it is just a matter of practice. It's a motor learning. It's a skill. It's like everything else. And you know what? Practice it. You have to practice nutrition. You have to practice strength training in order to get better. These things need to become habituated. So you know what? As early as possible is the answer to your question.
Yeah, I mean, it's scary what we see going on today with childhood obesity. I mean, you're seeing 5th graders acquire type 2 diabetes and atherosclerosis, and
Right.
It's so scary. You talk about metformin a lot, and it's a question that I get from a lot of listeners because I'm pretty public about everything that I'm on with testosterone, metformin.
Sure.
So I get a lot of questions on it, and obviously I'm not a specialist in that arena and qualified to answer those questions. But what just in kind of a nutshell, what is metformin, and why do I know when I met with you, like, hey, look, all my patients are on this, all my closest friends, family members, and this is like a must take supplement. What is it, and why do you feel everybody should be on it?
Right. So that's a good question. I'm gonna put it very, very general. We don't quite understand how metformin, all of metformin's actions. What metformin does, we believe, is it inhibits what's called gluconeogenesis from the liver. So metformin reduces the amount of glucose that's spit out from the liver, just in general, because one of the ways that we maintain our blood glucose is through hormones, glucagon, the two hormones, glucagon, insulin, adrenaline, epinephrine, norepinephrine, those two things also, and cortisol also has some interplay. But for the most part, insulin, glucagon, these are the big things. So by virtue of its ability to reduce hepatic gluconeogenesis, so how much sugar is released from the liver, which is a major, major, major storage center for glucose in the form of glycogen, which is just polymerized glucose. So glucose molecules that are stacked together, which is a more efficient way of storing glucose as opposed to storing them in individual molecules. By reducing the release of glucose from the liver, we are not necessarily becoming hypoglycemic, but what we are doing is I always tell patients that we're sort of lowering the body's need, if you will, to respond to those levels of glucose in the bloodstream by secreting insulin. So the net effect, if you will, and these are very, very loose. This is a very, very loose description. The net effect is that there's going to be lower circulating insulin. Our cells are going to be, by virtue or as a result of that, become more insulin sensitive because there's less of it around. They're going to be more responsive to that small amount of insulin that's around. And as you know, insulin, or the effects of insulin, I should say, are insulin's an inflammatory hormone. It's a vascular toxin. So the less of it floating around, the less close you are to developing an insulin-resistant state, the less bodily inflammation there is, the less atherogenesis, because insulin's a growth factor, and atherosclerotic disease needs to grow inside of your arteries, right? Think who develops atherosclerosis, right? Well, you can't sort of stereotype it, but people that have a lot of inflammation, and people that are insulin resistant. A lot of these guys are heavy. They're carrying too much body fat around. And what does body fat do? Again, it promotes inflammation and it promotes insulin resistance. So they're the two big reasons why you need to knock that visceral fat and body fat in general down. So metformin, by lowering the amount of bodily inflammation, follow me here, by lowering the amount of bodily insulin, puts you in a lower insulin state. When you are in a lower insulin state, you are in more of a fat-burning state. Does that make sense? Okay? Because remember, when your body sees insulin, when you eat the Snickers bar, inflammation goes up and you go into a fat storage mode. You are storing fat. So the opposite is also true. When you lower bodily insulin, inflammation goes down and you become closer to a starved state, right? Or a calorie deprived state. And metformin is called a calorie restriction mimetic. Okay? It puts you into more of a fat burning mode. Is it all of a sudden going to take off? You're going to take metformin and you're going to take off 30 pounds without changing your diet? No, that's not going to happen. But if you are reasonable about your diet, metformin is only going to accelerate that process. There is no pill that's going to do it unto itself. But metformin is going to drive you into more of a calorically restricted state, and that's going to drive the fat burning process even harder. Now, metformin also, and this is another, I guess it's another corollary. We're talking about how insulin is a growth factor, right? So Insulin's a growth factor. It grows atherosclerosis inside of your arteries. Cancer also relies on insulin and sugar, if you will, to grow, which is why cancer is detected by something that's called a PET scan. And when they do PET, which is positron emission tomography, what are they injecting into your body in order to trace where the tumors are? Do you know? Well, what they're injecting into your body is radio-labeled glucose. Well, the reason why is because the cancer cells love the glucose, and you'll be able to image it, okay? Because this glucose literally goes right to the tumor cells, right? This is a very, very highly sensitive test. So then the next question is, wait a minute. So if I live in an insulin-deprived state, I'm not putting a lot of sugar into my body, glucose. Well, maybe that's going to be that state where we are constantly burning fat, not necessarily ketogenic, but that state where we are in a fat-burning mode, maybe is the state that's protective of the body. So metformin, because it's I'll call it the anti-growth factor, the anti-sugar, the anti-insulin, is cancer chemopreventative. We have data on that. So we believe that metformin, and it's more than a belief because there's data coming out. We have some breast cancer data right now, which actually is very, very significant and impressive. Metformin in diabetic females reduces the incidence. In diabetic females, reduces the incidence of breast cancer by 30%. 30%. So then you have to start saying, well, wait a minute. Does this apply to other tumors? And it's turning out that it probably is going to. So there's there's brain tumor research being done on metformin because, again, it's anti-growth factor, anti-growth factor. You probably have heard people talk about the mTOR pathway. Call it whatever you want. It doesn't matter. It's a growth factor pathway. It's a growth producing and growth encouraging pathway. So you want to be sort of anti-growth. And then you may be saying to yourself, well, wait a minute. Well, we want to have big muscles. Well, there's a fine line that you have to ride. So is it going to potentially impair your ability to amass a significant amount of muscle on your body? Well, to some degrees it is, because bodybuilders, what do they inject? Well, they inject insulin, right? So metformin is sort of the anti-insulin. So yes, it is going to potentially impede your gains a little bit, but that's okay, because this isn't really about bodybuilding, is it? No, it's about health. As an aside, and I think I talk about a little bit about this in the book, Alzheimer's disease is called type 3 diabetes, because one of the underpinnings of Alzheimer's disease is not only inflammation, but insulin resistance. Go figure. So there are trials, the TAME trial, TAME, I'm sure you've heard that, capital T, capital A, targeting aging with metformin. One of the sort of the endpoints in there is cognitive decline, MCI, Alzheimer's disease, et cetera, et cetera. So they want to see how fast normal people, they're all that are non-diabetic, okay, so they have no medical comorbidities, particularly diabetes, how fast they're going to develop these diseases, these age-related diseases. So cancer, coronary artery disease, atherosclerosis, and Alzheimer's. Those are the three endpoints. And I can tell you with a high degree of certainty, I'd bet a finger, and that's a surgeon betting a finger, that this trial, which is going to take 8 to 10 years before the data is out, don't wait that long before getting on the drug, is going to be very, very positive. It's going to be overwhelmingly positive. And then the pharmaceutical industry is going to be sort of stuck because it's off-label, and metformin has been around for, I believe, 80 years. 80, not 18, 80. So it's a great drug. It has a tremendous number of potential beneficial effects. The side effect profile is extremely benign. Doctors will say, "Oh, Osborn's insane because he puts everybody on, and everybody's going to be in renal failure." That's just not the case, and we know that those studies were in all likelihood flawed. They were in diabetic patients that had bad kidneys to begin with, because a lot of them developed diabetic nephropathy. So the data, I think, was spurious. I've never had a patient ever, and probably never will, develop a problem with it kidney-wise. There's this whole talk about lactic acidosis, et cetera, et cetera. It just doesn't happen. I think that data is wrong. The only real side effect that people get from metformin is that sometimes they get some gastrointestinal intolerance. You get diarrhea, et cetera, et cetera, et cetera. But And the ironic thing about it, and Jay and I had an article in Iron Man about this. The ironic thing about it is that in Florida, we have this place called Publix. I'm not sure you guys have it out there. It's a supermarket here, huge supermarket chain. At the pharmacy, it's free. So free. So the drug that I think ultimately will have the most global impact in 8 or 10 years after everybody sort of figures this out, is free. Okay, and Big Pharma can't do anything about it. Now, do I think that they're going to have a molecular analog that comes out, a molecular analog of metformin, so a drug that's sort of related to metformin molecularly, and they'll sell it as the new anti-aging drug? Absolutely. There's no question they're going to. But it's going to be it's going to be the same thing. So metformin is a stronger, but works on the same pathways as resveratrol does, except it costs a lot less than resveratrol does. So that's the thing. The only thing about it is that you need a prescription for it. But obviously, resveratrol you can buy anywhere. But a similar type of pathway. It's a calorie restriction mimetic. I'll call it an anti-growth factor, an insulin sensitizer. Those are the things that it does, at least in my mind. That's how I explain it to patients.
Now, do you think that there's a lot of resistance from the media because Big Pharma can't make a lot of money on it? Is that why you get such a bad rap? Do you think? I mean. It depends where you fall in the sort of the conspiracy theory, the spectrum there. I'm not really, much for that type of stuff. I'm going to tell you that it's probably, it may be downplayed a bit by virtue of the fact that there's no money in it. Do I think that there's some sort of conspiracy against metformin? No, I don't. I really don't. It's just hard to get, on soapbox. I mean, we need guys like you, that have these massive audiences to tell people, hey, get it out there. I've heard, who did I hear talk about it recently? Tim Ferriss also has a, big big audience. He's mentioned it. And I think maybe Mike Cernovich has also talked about it. I believe he has. I think maybe I've had some conversations with him about it as well. So it's guys like you who have these big audiences that need to, sort of scream from the rooftops and get people, just heighten awareness. Because as far as I'm concerned, and this may be something that's radical to say, but I've never really cared about that. This type of stuff should be in the water. And another thing that I talk about, loosely in the book is that something else that should be, considered are, and a lot of people say no, they don't do this. It has all sorts of problems. It's statins. Statins, while I'm not much for, cholesterol numbers, they're very, 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 very aggressive and potent anti-inflammatories, very potent. So I work at a level 1 trauma center, as you know. But what we also have there is a spectacular stroke service. And we do all sorts of catheter-based endovascular treatments for them. And I will tell you that a colleague of mine has probably done, I would say he's probably top 15 or 20 in the world as far as number of cases that he's done from an endovascular standpoint. This is a spectacular endovascular surgeon. And he puts all of his patients on statins to the point where, and this is aggressive, he starts them out on 80 milligrams of atorvastatin, Lipitor, in the post-stroke period. This is a different subpopulation of patients, of course, but these are patients that have had the event already, so they're already in trouble. And I asked him, and he drives their LDLs down to 70, and I asked him, how many of these patients have you had that have had these problems that are associated with statins? So cognitive impairment, myalgias, so muscle aches, et cetera, et cetera. He said, let me tell you something. He said, and this is a giant patient cohort experience. The cognitive stuff, zero. The myalgias, he says, intermittently it happens. Use aggressive dosing of CoQ10. That's all. And as I had said in the book, if you want to fiddle around with your cholesterol numbers, you don't want to drop your cholesterol levels, too low, because your brain in particular needs cholesterol. But it's my belief that in addition to the anti-inflammatory effects, I don't believe that people's LDL should be running over 100, because those are potentially oxidizable particles which can get plugged up in the atheroma ulcerations, if you will,
within your endothelium, so within your vascular walls. So it's something I take it on a very, very low dose, and I've never, ever had a problem with it. I've been on it for I don't know how many years. So I use just a small amount of atorvastatin, and I only use it every other day. I've never had a problem. And I put it on. I ask patients if they, if this is something that they want to consider. If their LDLs are running just a bit high, and I'm a little bit uncomfortable for it. I'm uncomfortable with it, given their other medical comorbidities or risk factors for disease. And thus far, we haven't had issues. If you get too aggressive with it, you're going to have problems. But I think in very, very low doses, I think that these things are reasonable, and most people would probably benefit from them. So that's just that was just an aside. But if you want to talk about things that should be sort of in the water, drug-wise, it would probably be that. It would probably be statins, or low-dose statins. It would probably be some sort of antihypertensive. I was just talking to one of the ICU nurses this morning about the antihypertensive. She said, "Oh, I got on antihypertensives the other day because my doctor, I was feeling badly, and he decided that he found out that I was hypertensive. Again, another biomarker for disease, right? Blood pressure. Okay, and my blood pressure now is 135 on 85. I said, so is that good? And she said, oh, that's great. I said, no, it's terrible. I said, you want to be 110 on 70. You want to run, well, how low should it be? Well, as far as I'm concerned, it should be damn low to the, you shouldn't be dizzy, okay, but you should be pretty damn close, okay? And obviously exercise and diet have a big role in that. But if those things aren't working and you do need antihypertensives, then you get on them, and you get on them aggressively, because why would you want your arteries being hit, like this, when they can be hit like this, even if it's the difference between 130 and 130 systolic and 110 systolic. So even though your doctor is going to tell you that that's good, it's not good.
It's like we get told it's good based on the social norms of today, and they just keep getting pushed up and up. It's
that's right.
So then with hormone replacement, it's one of those things where, I'm driving hard in my businesses and, young kids, and, I'm experiencing a lot of brain fog, experiencing a lot of symptoms, which I had no idea was with low T. And then eventually I went and got checked. And before I met you, the doctor I was working with had me on Clomid and all these other things. I'm just feeling like crap. And then I meet with you and we go deep into this. And I remember you saying to me, the goal is to wake up feeling like almost like Superman every day. Not feeling up, waking up, feeling like shit, but feeling great, right? And it was I don't want to say instantaneous, but within about 3 weeks, right, where it was just such a night and day difference. So how, and I know it's something that you believe in, you do in your clinic with hormones, but at what point should people start getting their hormones checked? And because the reality is, man, with all these chemicals that exist, 10,000 chemicals on the grocery store shelves, we can't combat it. I had resistance for years. I'm trying to do it natural with eating organic and working out, but the reality is you just can't combat some of this stuff. So at what point should people start getting checked and paying attention to that?
Yeah, I mean, if you start developing these, the symptoms of hypogonadism, so fatigue, abdominal adiposity, an inability to maintain your skeletal muscle mass, you're developing some fogginess, sexual dysfunction. There's a whole host of these things. I have patients in my clinic that are in their 20s, and those are some of the special operations guys that we have here. Who have had a tremendous amount of stress, obviously, during combat, even during training. Some of these guys are starved, for months, and they get no sleep. It's a problem. Cortisol level gets driven up, and you develop what's called a cortisol steal phenomenon, where all your molecular substrate, so all the chemicals that are being used normally to make your sex hormones, so testosterone, estrogen, progesterone, et cetera, are being driven into that pathway from which you derive cortisol. And it's a steal. So you literally are stealing the molecules away from the testosterone and estrogen precursor pathway to make your cortisol, because you have to mount a stress response. So the answer to your question is early, if symptoms warrant. It doesn't matter if you're in your 20s. Now, we always have to take into consideration these individuals that are of childbearing age, The fact that they may have father, the guy may wish to father additional children, and I'm less aggressive with those individuals because there is a very, very small chance, it's very small, chance of inducing sterility in these individuals. So I'm not as aggressive with those individuals, but I do use, in those patients, I use beta HCG very aggressively. But if you are not considering this, and early 30s, my cutoff typically here is it used to be 35. I've become a little bit more loose with it because I've started amassing these special operations guys, and there are some guys who come to me and they're, okay, so they're 25, they're getting deployed, et cetera, et cetera. They've already been vasectomized because they don't want to have kids ever. What are you waiting for? So your response, Josh, I'm going to tell you, is a typical response. And I usually tell people 2 to 3 weeks. And I probably told you the same thing as far as when you're going to start feeling things. And I usually tell my guys, mental clarity, not going to be taking a nap on the couch at the end of the day. You're going to have more initiative to do things, and morning erections come back. Those are the 4 things I usually tell them that they can expect within the first 2 to 3 weeks. And it sounded like you were you were following suit. But an answer to your question is it's all symptom dependent. If you are feeling these symptoms, you should go get checked. And it's really age independent. So I'm not going to tell you that there is an age. We have some sort of loose guidelines in the clinic here, like I said, 30 to 35, because those individuals are typically, they may have had kids already, et cetera, et cetera. That's really where that number came from. But anybody can have, I've had, I think people that are even younger than, yeah, I do. I actually have a guy who has, on testosterone, this is a different situation. He has primary hypogonadism. He's 21. He's already on, but he needs to be. So we're talking about secondary hypogonadism here, not primary. But he doesn't make anything, nothing. So we've given him HCG challenges, everything, and he's just not going to be able to father children. That's a different situation than what we're talking about. The vast majority of men are going through. There's no age. It's just it's symptom dependent. Then we look at the numbers and we try to do everything that we can initially, if they're young, without putting, in other words, testosterone, using HCG, zinc, so a natural aromatase inhibitor. There are lots of Brazil nuts and try to drive their testosterone up sort of pseudo naturally, but if that doesn't work, they're going on testosterone. That's just the way it is. Now, do I have patients that want to have kids that still feel crappy on HCG? So they want to have kids, they still feel crappy on HCG. The numbers are deplorable. What do I do with those individuals? That's easy. I keep them on the HCG. I tell them to go bank sperm, okay, and then I put them on. So I have ways of maneuvering no matter what your sort of situation is, and I have, I don't know, half a dozen of those guys too, and that's totally fine. So there's always a way, because you have to understand this, and you do understand it. People, your viewership needs to understand this, is that if your hormones are not optimal throughout your life, you will feel miserable. You will. And if they're optimal, you're going to feel spectacular. So there's no reason why, even if you're 50 years old, 55, 60, your hormone profile shouldn't look like when you were 16. There's just no reason why it shouldn't be like that.
Yep. Yeah, and I always try to talk about it on the show because it's, and words can't really describe of the difference that you're at. I was having a conversation with a guy the other day. I'm like, I wonder how many marriages end because of low testosterone.
Tons. I can tons. No. That's a great question. But we know the things that the factors that fuck up marriages, and those would be money and sex. We all know that, right? So the sex issues are, and then the question becomes, well, is the individual's testosterone level low because you don't know which is first, the chicken or the egg? But I can tell you that having a bad relationship with your wife is certainly going to drive your testosterone levels down, because it's another stress. Then you're stealing again. So whenever there's massive in stress, and this is marital strife is obviously a massive stress. your cortisol levels are going to go through the roof. Your testosterone level is going to go down, and then you're going to hate your wife more. That's just the way it is. So the answer to your question is well, I'm going to give you sort of the opposite of that question. How many marriages would be fixed if we were to give people testosterone, or if they were to know that they have low testosterone? The problem is that despite all the media craze, hype, et cetera, it's often the case that people have absolutely no idea that they have low testosterone levels. They have no idea. And the doctors, a lot of them, they're not checking. We weren't taught this in medical school. We were not taught this in medical school. I can tell you that for sure. Here's an interesting aside. So I'm close friends with the chief of trauma surgery at St. Mary's, and so he comes to me one day and he says, "Listen, Brad, I got this guy who's on a ventilator, and he's been on the ventilator for about 6 weeks, and we can't get him off. He had a severe injury. It's polytrauma, so it's not just head injury, just a complete train wreck." And he says, "Can't get him off the ventilator. He's very, very he's cachectic. Okay, so he has no muscle mass. It's beyond sarcopenia. This is just frank, florid ICU cachexia, despite the fact that they're feeding him. Why? Because you are in a catabolic state when you're in the ICU, and we're constantly fighting that. You're losing everything. You're losing body mass. You're losing fat and muscle." He said, "It's been 6 weeks, and we can't get him off the ventilator." He said, "Do you mind helping me? Put him on testosterone. Tell me what the right dosage is, and tell me if I need to put him on anastrozole and blah blah blah." I said, "Sure." So we write him for testosterone. Okay, 10 days later, he's off the ventilator, and we've done this now about a half a dozen times, to the point where now we're teaming up with University of Florida to do a study on this, on testosterone usage in ICU patients that are ventilated. And again, now I'm not going to bet one finger like the Metformin. I will bet you a hand, okay, that this study is tremendously positive in favor of testosterone usage in individuals who are in the ICU. Why? Because again, you are in a catabolic state, trying to your best to mobilize resources, recover and patch up your wounds, if you will, with the protein that's stored in your muscle, et cetera, et cetera. And by virtue of that, you're losing your muscle mass, so you have no respiratory drive anymore. And by starting testosterone early in these individuals, I believe, and it's the same thing with my big lumbar spine cases, where we're cutting through the back muscles and burning them and spreading them apart, and they become devascularized. I believe those patients too should be on supplemental testosterone as well. So that's just an aside, but I think it's a great drug, not to be used in super physiologic dosages, and it's as far as side effects, problems that I've seen with its usage, just like metformin in my office, these are unusual, and I would say they're just rare. They're rare, despite what the media may want you to believe.
Yeah, I mean, it gets a bad rap because of the abuse with athletes, or these professional bodybuilders are taking ungodly, unsafe amounts. I mean, we're talking very low dose just to get you back to, as you say, homeostasis, to how your body should be operating.
That's right. That's exactly right. I'm just going to walk through the office here, Josh. I need a plug.
Okay. Yeah, well, I know you're a busy man. I got a couple last questions for you.
Sure.
Yeah, and going back to that too, if we just look at with the media, I don't know if you saw that post about Donald Trump, how they said, records came back good, but it was strange that his doctor tested for testosterone. And I'm like, well, why would one of the most important hormones in our body be strange to get it tested for? So it is odd that we have that mental stigma of it. But and I know in Get Serious you talk a lot about working out and a lot about resistance training. So coming from not just this health and fitness expert, but a neurosurgeon, and you wrote that book from a surgeon's perspective. For those that are working out, because we see a lot of these, CrossFit style, Orange Theory styles, all these things building up. I mean, with your experience from being a neurosurgeon, is there a better way for the body, a healthier way, long term, to go out there and resistance train and do your cardio that people should be paying attention to, compared to deteriorating and tearing down your body?
Right. So, the CrossFit thing is an hour-long explanation, so we're not going to get into that. I'll just tell you that it's very bad for the body for a number of reasons. If I could, the best way, in my opinion, to strength train would be to, just like Get Serious says, and it's not just because it's mine, because that's not my program. It's a sort of a hybridization of several different types of programs, but one that seems to work for me and work for individuals that utilize it long term. The best way would be stick to basics, make progression, don't do anything quickly. Be sure to pay attention to your body mechanics and technique. And one thing that is, it's the most important thing, and I'm going to tell you this, and you can talk to anybody that has experience. The way you're going to ultimately make progression in this life, particularly as you get older, with regard to your strength level, physique, whatever your endpoints are, avoid getting injured. You can avoid getting injured just by virtue of you standing there and doing the proper movements, exercises. The progress can be incremental, but as soon as you get injured as an older individual, even on testosterone, even with a clean diet, you're going to suffer, and you're going to suffer for months. So an injury, I mean, I've been dealing with sort of an ailing shoulder, and it's taken me 9 months to recover from this problem that I have. And I've come to the realization during this time period, I've spoken to other individuals who've been injured as well, and everybody seems to be in agreement. If you can just maintain your body in its sort of its pristine state, an uninjured state, it's like compound interest. It's just very, very slow, but uninjured, unimpeded, and you will do great long term. So that's something that's a recent realization for me, within the last 9 months, and its impact has really affected my training to a great degree. While I was very, very careful before, I've done a little bit more. I put a little bit more emphasis on sort of mobilization techniques in gym. Brown helped me out during our last SOAR event, but I've since become even more interested in that type of stuff. So it's not stretching; it's becoming strong, if you will, in the positions where most people are not strong. It's developing that athletic strength. It's getting hit by if somebody's trying to tackle you, you're wondering why the 160 pounder can push around a 230 pound guy. It's because he has a different type of strength. It's strength of the accessory muscles. It's strength in positions that most individuals don't have strength in. So it's paying attention to how well your rotator cuff, how strong your rotator cuff is. Now, I'll ask you, when was the last time you did any exercises for your rotator cuff, which are very, very protective of your shoulder, so your labrum, your biceps tendon. So when was the last time you exercised your supraspinatus, your infraspinatus, your subscapularis? When was the last time you did those? Your teres? Probably never. That's right. That's right. But I'm going to tell you that in addition to sticking to the basic movements, you've got to avoid injury. You've got to start working on some of these supplemental, smaller muscles, your hip external rotators, okay, which is just like your ability to go like this, right? Your external rotators of your hip, okay, piriformis, these teeny little muscles with funny names, et cetera, et cetera. These are critical to injury prevention, and by virtue, your progress. Because if you're injured, you're not making progress. But as far as the other stuff, the other silliness that's out there, these other obstacle course racing, this CrossFit stuff, whatever you want to call it, exercise, as far as I'm concerned, is not made to be moved through quickly. And I'm not talking about set to set. That's fine. I'm talking about intraset. So a snatch is a single, first of all, it's dangerous to begin with. It's for advanced lifters only. But it's a single repetition movement, period. So why have we turned it into a race? Because you know exactly what's going to end up happening when you start turning it into a race. You're going to get injured because your technique is going to be affected. And I see it constantly. I had one already this week, a CrossFit injury. We see it all the time. All the time. And if your exercise, whatever you want to call it, you can call it CrossFit, you can call it other silly names and things like that, I don't care. If your exercise ultimately is serving a detriment to you, you're getting injured routinely, it's not serving its purpose. So if you stick to the basics, the things that we've been doing for thousands of years, deadlifting, lifting rocks off the ground, et cetera, I'm just going to use that one movement, and you do it carefully, progressively, with proper technique, you're going to be stronger, I can assure you, in 10 years than you would be if you did CrossFit for 10 years. Why? Because not only are you in a constant catabolic state because they want you to come there 5 days a week, your cortisol levels are through the roof, but you'll also be in a hospital bed, where you won't be if you do basic movements and pay attention to, like I said, the mobility and really injury prevention techniques. So that's, I think, the secret to it all. And that's one of the things, actually, because I was less aware of it when I wrote the book. There's a small little warm-up blurb in there, but it's really beyond the warm-up. It's on days that you're off. It's about doing some, not stretching, it's about doing some mobilization type of work, which make you stronger in those awkward positions. So when was the last time you trained to extend your arms? So we're anterior people. So anterior is here, in front of, okay? Posterior is here, okay? So when was the last time you trained your ability to bring your arm backwards? That's right, okay? And this is something that is, again, important for our full body strength, because you don't want to be anterior, anterior person like everybody else. We're, like the T-Rex. We're doing this all day, right? Okay. You don't want to do that. You want to have balance. You want to have muscular balance. You want to be able to not walk around hunched over like the guys who think they're really strong. You want to be able to walk around shoulders back. You want to be able to pull your shoulder blades downward. Okay, and that's going to create a balance in the shoulder joint, and it's going to predispose you to less issues with your biceps tendon, your labrum. You're going to be more stable on the bench press. But most people never train this. It's a hard movement to train, just like this. This is why people, if you watch them, you may have do muscle-ups. People can't do it because they can do a pull-up. You can get those rings here, right? And you can certainly do a dip, right? But the transition part, which is shoulder extension or arm extension, is very, very hard. That's why most people can't do a muscle-up. So you have to train these things that you didn't think were important before, but they are to keep the balance across joints. And that's going to prevent asymmetries in movement, et cetera, and it's going to keep that shoulder joint really, I keep saying the shoulder because I injured my shoulder. It's going to keep that shoulder joint really, really tight. And that's how you're going to prevent injury, prevent degenerative disease, et cetera, et cetera. So that would be my point. Basic movements, those would be my 2 big points. Basic movements, progress, doesn't matter how heavy it is, you want to continually strive for progression, and make sure that you are doing some sort of mobilization / strengthening the smaller muscles that are integral to your joint. So those would be 2 big points, and stay away from the garbage, because I always tell people, I had a guy in here, I told you this guy was injured, just this week. And I said to him, he's 45 years old, a 45-year-old man. And I said to him, man, you are way smarter than me. If you want to be stupid, you can go and do the silliness. Okay, but that's an immature mind as far as I'm concerned. It really is. It's an immature mind. You haven't thought about what you're doing. What's the end point of doing the CrossFit stuff? What is it? What are you waiting for? Are you waiting for your injury to occur? You're certainly not going to go and compete with guys like Froning. Okay, it's never going to happen. That guy's this is a master power lifter. It's just not going to happen to the average Joe Schmo. It's just not. Okay, and so I don't really see a reason to go and do that stuff. Well, I like doing it because it's sort of it's the culture and things like that. You know what? I train in a powerlifting gym. We've got some guys there. It's great. It's you can find it anywhere. You can find the camaraderie anywhere. You don't need to go to a CrossFit gym.
Yeah, and we find that pattern in every aspect of life where people aren't thinking about the long term. They're not thinking about, hey, what happens when you're 70? Whether it's with your way that you work out, with your diet, with your finances. People just aren't. They're thinking about the now, not thinking about the future. So, a lot of our listeners are kind of, hard chargers, entrepreneurs that, of course, take their health seriously, and a lot of them are taking their health seriously so they can charge harder in entrepreneurship. A thing that always comes up with my guests is, sleep. Hey Josh, what's the right amount of sleep? I've got kids, I got these businesses. They're always trying to look to biohack sleep. From your standpoint. Are there any hacks? Is there like an amount that, hey, if you don't get this, like you're just going to be doing dangerous things to your body? What's your take on that?
Right, and that's a good question. A couple of things. Sleep deprivation is cumulative. Okay, so you will have to catch up. There is no definitive hack. If you are thinking about hacking your brain, to sleep, in other words, trying to make yourself sleep less, I think that you're doing yourself a disservice. We all know that neurodegenerative disease is very strongly, intimately associated with sleep deprivation. Don't do it. I wrote a blog on this on my website about how during REM sleep, your brain is literally, I'll just use the term loosely, it's washed free of toxins that accumulate in neurodegenerative disease. We know this for sure. There are something that these things are called not lymphatics, which typically are the channels that remove waste from the external environment of the cells through, they track in these lymphatic channels into lymph nodes. There's a lot of white blood cells. The white blood cells clean up all the gunk, if you will, and then the lymph ultimately drains back into the venous system. The brain was thought never to have these things. So where does the neuronal waste go to? Well, it turns out that it probably does. We have termed these loosely lymphatics, okay, glia, okay, so if you will, brain substance. Brain supporting tissue is the glia, not the nerves. There are these very, very ill-defined channels within the brain through which spinal fluid flows and washes free these toxins which accumulate during the day. That mostly occurs during REM sleep. So you can't hack sleep. Everybody is individualized in the context of sleep. So there are some people that need 10 hours of sleep. My girlfriend, for example, she needs a lot of sleep. There are some people that need much less sleep. So I can go on 5 and I'm good. If I have to pull, an all-nighter, which I did last week, for a case in the operating room, I don't do well, and I don't do nearly as well as I used to during residency. I'm less and less tolerant to the sleep deprivation, which is why you don't see any SEALs that are fit, right? They're not going to tolerate it. They're younger. They're typically younger guys. As far as what you should be doing in order to optimize your sleep, the usual stuff. Shut the phone off. No TV in the bedroom. Dark, cool room. And something that I use very, very aggressively is I use very, very high doses of melatonin. So if there's going to be one hack, one thing that I think probably works best to induce sleep and ensure that you stay down, I would say that would be melatonin. And you can be pretty liberal with it. Your doctor may tell you, well, your doctor won't tell you, but somebody will tell you that, you can start off with 1 milligram or 3 milligrams. I routinely, every single night, take 12. Okay, my mom takes 40. It's not going to hurt you. It's the precursor to serotonin, which is a sleep-inductive chemical in the brain. So use it, and you can use it. You can use it every night, and it also happens to be a cancer chemopreventative agent. So I think I've said this before. Blind women who have high levels of melatonin, because the production of melatonin is shut off in the presence of light. So they see no light, so their brain levels of melatonin are high. They have a reduced incidence of cancer, breast cancer. And people think that so by virtue of that, melatonin is a cancer chemopreventative agent. Now it may be multifactorial and totally spurious data, but nobody knows. One would like to think that it's true, and it's a great substance for sleep induction and maintenance. And what you want to do, and this is what I use a slow release melatonin, so it sort of lasts throughout the night, and it'll keep me down for my 6 hours. But again, that's something dosage wise that an individual needs to experiment with. But I would strongly suggest not trying to deprive yourself of sleep, even though we want more work hours. We want the other thing that I have come to realize is that when you're done with work, say as an example, you're done at 8 o'clock at night, you're done. Leave it alone. Give yourself some time to your brain to settle down. High levels of cortisol are going to be very, very interruptive or disruptive to your sleep. Okay, and again, high levels of stress, poor REM sleep, obesity, bodily inflammation, insulin resistance. These are all precursors to Alzheimer's disease. I may sound like a broken record, but this is just the truth.
Yeah. How do you know? I mean, because you're saying, okay, hey, you can operate up for 5 or 6 hours, but your girlfriend needs 10. You know, what were some of those signals? If you're trying to find out the amount your body needs, what are some things we should be cognitive of and paying attention to that our body's either saying we need more or less?
Right. I mean, I just think that I don't think there's anything aside from that's an experiential thing. So you just need to experiment. And you see how you do the next day, see how your training is, see what as an example, you can see what your resting heart rate is when you get up. These are things that you can do. So they're performance indicators, just like everything else, KPIs, just like you talk about these things, right? So it's just over time, you need to log how much sleep you're getting, keep a sleep log. People do. Keep a sleep log and see how your performance is the following day or 2 days later, 3 days later, whatever it is. You can sleep 7 hours and try to get 7 hours, and just do it like that. There are no ways. So there are no I'm going to say tests or biomarkers aside from experience and experiment. I should say, experimenting on yourself that are going to clue you into what's an optimal level of sleep. I mean, I would think that most mature individuals sort of have an idea as to where they are. I can tell you for sure that she is just no good when she doesn't have at least 8 and probably 10 hours of sleep. So I can't give you any test. If your sleep is very, very interrupted, you feel lousy, and despite the fact that you've changed hours of sleep, use melatonin, et cetera, I would encourage individuals to go and get a sleep study, a formal sleep study. Because oftentimes individuals that, even unsuspecting individuals, are diagnosed with sleep apnea. They may benefit from a CPAP or a BiPAP machine. And that's a very, very common diagnosis nowadays. Very, very common. I'm not saying that's right or wrong. I'm just saying that I have friends, many of them, who are on BiPAP machines, and they say, listen, before I was using a BiPAP machine, I couldn't sleep at all. Now I have this thing, and it works great. Not the sexiest thing in the world, but it does work. Sleep is critical. You have to get it. You cannot go. You're not 20. You cannot go on 3 hours of sleep anymore. I used to do that in residency all the time, and it was just it was more okay then. You still felt shitty when you had to go and operate after being up all night for 12 hours. I'm just less and less tolerant of that now. So when I have to go in the middle of the night, I'll back the patient load off the next day. I'll make sure I get some sleep, try to catch up. Don't get behind in sleep. Do not. Okay, I want people to start thinking, sleep up, sleep down, cortisol levels up. Your sleep average are off, your cortisol levels are going to go through the roof, and they're going to function poorly. Period.
Yep, love it, man. So last question for you is, I know you're a busy man. So we live in this world where people are acquiring ADD, right? With all, their cell phones and Facebook and all this stuff going on. And a lot of people lack focus on a very high level. But you're a dude, you might be in the operating room for 6 hours. Like, you can't not be focused. Do you have any recommendations that help you focus for long periods of time like that? Like, do you meditate, or is it just one of those things like where you just don't have a choice and you're there? Because we see so many people suffering from focus today.
Yeah, that's a good question. I've been trying to work on my sleep, as I had said. So I'm like yesterday, I did a case that was exactly what you said. It was about 6.5 hours. when you're operating, like it's different because my focus is there's no not focusing. Okay, when you're doing something like that, so it's sort of a different story. When you have somebody's life in your hands, you're going to focus. Can you get distracted? Sure, you can get distracted. Somebody's, pissing you off in the door, which happens. Things are not going so smoothly. Sure, you can, be sort of a sidetrack, at least temporarily. But you get back on point fairly quickly. As far as just day to day, I've been fiddling around a little bit with Headspace. You familiar with that app? Yeah. So I've been fiddling around with that, and that's pretty neat. And I think that probably sets the tone for the day. And I know you're big into this. So I think that has its role. And I've actually have 3 books on my desk right now, and I'm an avid reader in my spare time. I've been reading a lot more about that because there's definitely something to that. And I think that sort of sets the tone of the day. I think that you should do it in the morning. That really calms the mind down. I think that one of the problems with society today is that, as you had said, there are too many distractions. We don't take time out for ourselves, and we don't just turn it off for a little while. So sometimes in the operating room, I did it today, and things were going fine, but they draped the microscope. So there's this big sterile drape on the microscope. Okay, and the guy who was assisting me, he tells me, he says, "Hey, Dr. Osborn, I can't see in through my scope." So he's directly opposite. We're doing a neck, not like yesterday. We're doing it from behind, but the neck from the front. And he says, "I can't see." Says, so I said to him, "Does that mean it's blank?" And on your through your oculars, yeah, I can't see. I can't see the surgical field. So he said, "What do you want to do?" Because then he can't help me. So I said, "Robert, change the drape." And I just remember when they were changing the drape. Okay, I was standing there. I closed my eyes for 10 seconds, and I just took a bunch of breaths. Okay, and just to get rid of the immediate stress because they had screwed up the microscope, and just sort of restarted. So I think eliminating distractions and resetting your mind, I think are big things. And if it means taking Facebook off of your phone, or Snapchat, or this other silliness, that serves only as a distraction, something that we have to respond to, and just sort of internalizing for 1 second, and sort of just gathering your thoughts, gathering your calmness, and just sort of being in the moment for a second. I think that does help. So I've been learning to do that ever since I've been fiddling around with Headspace. Do you use it every day?
Yeah, well, I used it to get into meditation. My wife uses it, but I've got
yeah. I think it's great. I really do think it's great. So you're doing more than 10 minutes?
Yeah, I do 20 minutes in the morning, 20 minutes at night. I'll email you when we get done my meditation routine. But I went to a meditation retreat, and
oh, you did?
I actually just shared it with Jim Brown. He's like, "Dude, I felt like I was levitating for 90 minutes going through the meditation routine." So I'll send it to you. It's pretty gnarly.
Yeah. I'd like to see that. I really would like to see that. But I think that's a big thing. So if you're asking me what do I, that's probably my newest thing. In that regard, I'm not going to tell you, "Oh, I have some drug that's going to make you focus." I'm sure you probably have seen some of the Facebook stuff that I've done on these oral ketones. I think if there's anything that's a very, very good brain fuel, I would say eliminate the carbohydrates. And during a long procedure like yesterday, before I went to the operating room, I had a whole thing of ketogenics. And I think that's and I had a little bit of, I had some green tea capsules. And I think that those things sort of keep me, my brain working really, really well. I didn't have any breakfast. Not having breakfast, I think, is, it's not the best for bodybuilding or whatever. I think it gives you a higher degree of mental clarity, I think, or just fueling your body with fats and maybe just a little bit of caffeine, I think works great. But again, these are not necessarily eliminating distractions. These are just really about getting your mind working, sort of well and straight, if you will. But those would be my only tips. I'm not going to tell you I have some advanced brain hacks and things like that, or use modafinil and stuff. I'm not going to tell you that. because that would be a lie. I think that my newest thing, I would say within the past maybe year, is to evoke a new sense of calmness. And that works. The other thing about it, Josh, is, and I don't know if you do this, is that have you learned to do, so use some of the techniques, if you will, that you do during meditation, albeit in a truncated manner during your day.
Yeah, just try to snap yourself in.
Yeah, so what do you do?
So so in my meditation routine, I actually go into, I visualize myself walking into this boardroom, if you will, opening up the doors. There's a whole routine. But during the day, if something goes on, I just need to get clarity really quickly. Yeah. I mean, I'll just put myself right in there. So I've got this whiteboard. I have two people that represent my subconscious that I instruct throughout the day of what our goals are and what our long-term goals are. So I'll just snap myself where instantaneously I'm in front of them, which is a whole new sense of calm, whole new sense of refocus. But I've done it so long that I'm able to, I mean, it feels like it's real,
Right. No, I think that's great. I'm learning to do it. Like I said, I just did it this morning. Sometimes I'll do it while I'm driving because somebody will call me and it'll be about some annoyance at the hospital or something's going wrong with the patient. And then, I would say I would probably be more reactive. And I don't think that that's good serially, for your health. And neurosurgeons age poorly. We age poorly because, of all the stresses, and I'm not a stressed guy, but I think that this sort of, flies under the radar, and cumulatively, like sleep deprivation, I think it takes its effect. So you must have some sort of way to combat that. And I think meditation is very interesting. I've always been interested in it, but I never have created the time. But now I think it's my time to create the time.
Yeah, I love it. I'm one of the guys that I do experiment. So I've experimented with modafinil and a lot of these other quote-unquote smart drugs, and nothing is compared to metformin. Or I mean, not metformin, sorry, meditation. Right. Right? Right. Like, I mean, it's just far as, because a lot of that stuff too, your body builds resistance to it, and it just, I mean, meditation, there's a reason that so many of the greats do it. You read like Thomas Edison. He used to sit in a rocking chair with a rock in his hand with a metal bucket, and he tried to get, when he meditated, like try to be the conscious and the unconscious, like right in that time. So he'd have that bucket while he was meditating with the rock. So if he fell asleep, the rock would release, hit the metal bucket, and wake him up so he could get back in that state. There's a brilliant book out there called Daily Rituals. And it was written, it was all the 500 greatest minds, or whoever wrote it classified them as the greatest minds, like Mozart and, Picasso. And each page is devoted to their daily ritual, their daily routine. And meditation is something that you just see common over and over and over in all of the greats, whether it's a great artist or a great entrepreneur or inventor. It's something that they all seem to have in common.
Mm-hmm. Interesting.
So,
and not surprising.
Yep, love it, love it. So, all right, you guys, well, those of you that are watching and listening, make sure that you go we'll have links below to go pick up Get Serious. It's a book I know you've heard me talk about many times. It's a brilliant, brilliant book. Like I said, by far the best book I've ever read on overall fitness health. It's not just from some, bro that's in the fitness space that wrote a book. It's from a trauma surgeon of 20 plus years of how to go out there and live the best, healthy, long life, right? So go pick up the book. Also, with Dr. Brett Osborn, my wife Amanda and I, we fly out every single year to Florida. We go through all the testing, making sure our heart's healthy. They go through and test our arteries, go through a series of testing. There's no better ROI. I know we talk all the time in the show about ROI. There is no better ROI that exists out there than taking care of yourself first. I had a guest on that. It was a fitness trainer. He said, it's so weird. We spend our whole entire youth making money, and then we spend our later years in our lives spending the money to recapture back and retake care of our health. And it's the opposite approach. So make sure that you reach out to Dr. Osborn. Check out his book. I highly recommend that you guys go see him, take care of your health. And Dr. Osborn, this has been a massive honor. I know how busy you are, and I really appreciate you taking time to come on the show and share all your knowledge with us.
Thanks very much, Josh. Thank you very, very much. I am a big fan, by the way.
Yeah, love it, man. Truly means a lot. All right, you guys. Well, thank you so much, and we will see you next time.